Floating head is a big challenge. People usually think that floating head should be easy compared to a deeply engaged head. Yes, deeply engaged head has its own challenges. Dr. Suchitra was supposed to talk about it. I'm sure she is going to shortly talk on that. That's a big challenge. But then floating head is also a challenge. Usually, the if the head is just gone into the pelvic brim, or if it is engaged, just engaged, it's very easy. The method that we use is what we call just lever out the head. In fact, in one of the DNB exams, the examiner asked the student, what is the role of the thumb? Most of the student could not answer. The answer is there is no role for thumb. In other words, we do not grip the head and pull out the baby. It is impossible to hold the head and pull or lift anybody. However, it is easier to pull others' legs, both metaphorically as well as during cesarean section. So, with that as an introduction, let me now give you different scenarios of floating or mobile head. The commonest scenario is a preterm baby because here the lower segment is not well formed and usually the head is high and not engaged. And here also we have to be a little careful. The baby is smaller and the head is also very softer. The bones are not, ossified properly, and the sutures are also not ossified properly. There's a wide gap. So how do you manage? Well, you can manage this in the same manner as other cesarean sections by putting a lower transverse incision, but many books, many authors suggest a low longitudinal incision. This is because we can actually extend the incision little higher if you need. It is always easier to extend the longitudinal incision compared to a transverse incision. But one has to be careful not to extend the longitudinal incision lower because it can encroach the base of the bladder. Now, people have also suggested classical cesarean section for preterm baby, but all of us know classical cesarean section is a no-no in modern obstetrics, except very few conditions like maybe sometimes conjoined twins, or if you are going for a cesarean hysterectomy, or if you are going doing a cesarean section in a cancer cervix patient. Whereas low longitudinal incision is the most preferred incision to deliver a preterm baby whose head is floating. But as I mentioned little earlier, a lower transverse incision is also okay. But then you have to follow the same principles which I am going to tell in case of a term baby with a floating head. Now, what is the principle that we follow? There are different principles that we can follow. One is manual delivery. The other is an instrumental delivery. Let me talk about manual delivery first. Here, the incision has to be as low as possible. This is very important to understand. My professor and HOD used to say, even if it is an elective cesarean section, it is always advisable to do a per-vaginal examination before you do the cesarean section to know the length of the cervix. If the cervix is long, then the incision has to be as low as possible. If the cervix is very short or taken up, then the incision has to be as high as possible. After a low incision, you have to insert the hand below the head before the head slips this side or that side. This is very, very crucial and important before applying any other technique. Now, once your hand is below the head, then you should not rush to deliver this baby because it is slightly difficult as the head is floating and high. What you have to do is you have to allow the liquor to drain little bit. Once the liquor goes down, slowly the head will slide on your palm. And now is the time it is easier to hook out the head. Should you have any difficulty you can ask your assistant to give a slight fundal pressure. In fact, you don't even have to ask. Nowadays, all the anesthetists are very well versed, and without your asking, they offer to give the slight fundal pressure that is required. With this simple technique, most of the floating head can be delivered. Now, the next thing is, before I go to the next technique, I am showing here what is actually meant by slight fundal pressure. So you put your hand beneath the head first, allow the liquor to drain, and then gentle fundal pressure will complete the job. The next one is, as I said, instrumental delivery. In that, the first preferred, the simpler, non-traumatic is the vacuum delivery. Non-traumatic both for the baby as well as for the mother. But we must remember that vacuum delivery at cesarean section is only for the term baby and not for the preterm baby, because anyway, even in vaginal delivery, vacuum is contraindicated for preterm baby. Now, usually it can be the same vacuum that you use, or you can use a silastic cup as well as, uh, you can use a kiwi's cup at the time of cesarean section. The only point is, if you're using just the cup with the attachments instead of a kiwi's cup, then you need to have a long tube. And this should be always kept ready, because you cannot go and search for this at the nick of the time. In Manipal, we always had a vacuum in the OT also with a long tube. And then, of course, where to apply the vacuum cup. Of course, as in case of vaginal delivery, the cup should be applied as posterior as possible. We don't have to measure here the vacuum distance and all other things. The posterior as possible is because while we deliver, we know that we have to maintain the flexion of the head. That is the most important aspect. Now, that is exactly why another important tip is, before you do the cesarean section, before you do the pervaginal examination, you must have a abdominal examination and a clear-cut idea which side is the back, because usually the occiput is on the same side as the back. Okay, so once you know that the back is on the left side, this vacuum cup can be applied onto the left side of the head, which is obviously more towards the occiput. And once you apply this, then you can actually deliver the baby in the same manner, maintaining the flexion of the head. Now here it is a kiwi's cup, as you can see here. Apply the cup, and it is just a hand driven, and you can create the vacuum. And most important thing is maintaining the flexion. That means, as in vaginal delivery, we always, the traction is in the direction perpendicular to the head, and maintaining the flexion of the head, that is very important. You may anticipate some extension of the incision either while applying the cup or while delivering the baby, or both, and you have to be ready for that as well. The next instrument is a forceps. Well, in a deeply engaged head, it is a single blade, or there is a special instrument called vectis, because you cannot apply both the blades in a deeply engaged head. This single blade will act like a shoe horn. Whereas in a floating head or a mobile head, you need to apply both the blades. I want to underline both the blades. Now, which forceps to be used? You can use an outlet forceps because the head is just there. It is not very deep. So there is no need of a low cavity forceps or any other type of forceps, just a pair of ordinary outlet forceps. Again, this is a very, very important instrument, should be kept in a OT for delivering the mobile head. Now, how will you do this? So you can actually use the left blade as the lower blade. There is nothing like left and right here, because usually in a floating head, the head is in a transverse position. So the left blade will be like a lower blade, and on top of that, you can apply the right blade. And here, once you apply properly, this is obviously a cephalic application, because here left blade goes to the left side of the baby's head and right blade goes to the right side of the baby's head, even though we use it like a lower and upper blade. And then you deliver the baby slowly as shown in the video. And once you deliver the head, then of course you can disconnect the blades, and then of course you can complete the delivery. Now, it is very, very important to note that not everybody can use this. I have used it couple of times for a floating head, not to actually use it as a method of delivery, but to demonstrate that it can be done. So it is always important to apply this on a mannequin and try this, whether you can do this or not. So here, as you can see, as in vaginal delivery, we have to do a phantom application first. Then you have to put hand below the head, and on the left side, the left blade goes to the left side, right blade goes directly onto the right side. Every time you have to guard the blades, not to injure any soft parts of the mother or the baby, and both. Here it is very important. Extreme gentleness, extreme caution is very important, and then you slowly deliver the baby. So that is about it. And the final or the desperate attempt is to convert the cephalic presentation into a podalic presentation. Because if you remember, what I told right in the beginning of my talk is that it is impossible to hold the head in your hand and deliver the baby, but it is always easier to pull others' legs. So what you do here, you put your hand inside all the way, catch hold of the ankles of the baby, and slowly do the internal podalic version so as to convert the cephalic presentation into a podalic presentation, followed, of course, by breech extraction, because you have to do all these things in succession and immediately. There is no assisted breech delivery here, but it is usually a breech extraction. But having said that, you have to follow the same principles. That is, the back of the baby should be facing the obstetrician. And when you pull the baby, it has to be parallel to the OT table and not at an angle to the OT table, because if you pull at an angle, then the baby's head will go for extension, and that will be extremely difficult to deliver the baby. So as you can show in this graphics, that you put your hand all the way inside, catch hold of the ankles of the baby, and gently rotate. Now, these things have to be done with extreme caution, and then, of course, you will be delivering like a breech extraction. If it's a very thinned out uterus, if there's a baby is big, this procedure can be extremely difficult. But this is the only option. The other option could be converting this transverse incision into a inverted T incision. But then, whenever you give inverted T incision, please remember the incidence of rupture of uterus is same as that of a classical Caesarean section. So if it is a primary gravida, then you have to counsel the patient beforehand that this is one of the possibilities that we may have to do, and all the other consequences. If it is a multigravida, then of course it is prudent to have taken the consent for sterilization. And if you had to have a inverted incision, you should usually follow that operation by bilateral tubal ligation. So that's all I want to talk about the floating head. Thank you so much for the opportunity.